Hi, my name is Katie Beth Dungy. I'm here to apply for the maintenance of my NCAP Level 5. Jumping right in, I have my letter verifying that I have my hours. I also have my certification in medical surgical nursing, my CMSRN, I have my BSN, and I have my signed application from my manager verifying that I am eligible. I have my peer reviews in here as well, so I think that makes the first part of the basic requirements. I'm going to start with my exemplars, kind of going over them real quick. So my first one was about a patient we had on the unit almost a couple years ago now, and she had a progression of MS that had left her a little bit confused. She'd been on our unit for a couple of weeks. I had gotten to know her pretty well. Some points in time she'd been quite lucid, so I really did get to know her quite well. It was kind of very emotional for all of us as she had progressed through the disease to the point where she had gotten really confused. I had not been her nurse on the day that the exemplar happened, but I was on the unit and I walked by her room and I heard her calling out for help. She was pretty distressed. So I went into the room just to check on her and see what was going on. When I was asking if she's okay, she just kept saying, I want out of here, I want to leave, I'm getting up, I'm leaving. At that point in time, she had lost her ability to walk already and she was pretty weak. But I also knew that she was really agitated and that she was pretty focused on leaving. So I started to think about what I might be able to do for her, what I might be able to do to help her kind of calm down and relieve some of that anxiety. I called the primary nurse. I told her what was going on using SBAR as my HRO tool. And I talked to her about maybe being able to take the patient out of the room in the bed and just kind of take her around the unit and get her out of the room for a little bit. I had just checked on my patients and finished hourly rounding, but I did let my PCT know that I was going to be preoccupied for a moment and asked if she could keep an ear out on our patients. And with that, I got the bed ready. I got everything that I needed to set up, and I took the patient out of the room on her bed, and I kind of took her around the unit. I took her down the hallway to look out the windows for a while. I talked about artwork, and she kind of listened, and as we went, she got quite a bit calmer. I, after that, followed up with the doctor and as well as the nurse to let them know what had happened, and they actually wound up setting a family meeting or a family conference based on that. I didn't really have any complications at that time, and my final outcome was that the patient really did calm down. My lessons learned, I learned to address all of my patients' needs and try to discover unique ways I might be able to increase their comfort, and no complications arose. And then my Duffy's caring factor was attentive reassurance, and my HRO tools were the SBAR. And then I also used STAR, stop, think, act, and review when I first arrived to the situation. The other day that I was going to use for my other story was a patient I had that had quite a significant amount of health history as well as comorbidities. They had a lot of allergies. We were starting some new therapies for her, and she was very, very anxious about kind of what was going on and what the end outcomes were going to be. So I kind of went in and I talked with her a little bit, and I was talking her through some different examples we could use because she was very tearful. I spent a lot of time trying to communicate with her throughout the day, keeping her as updated on the plan of care and as involved on it as I could. I went in at handoff with my other nurse, and I noticed that she was still really tearful and kind of upset. And she just kept saying, I'm never going to get better. I feel really bad. I'm never going to get better. This is just going to be the way it always is. So my concerns was that I was concerned not only for her medical conditions, but just her overall well-being, including her anxiety. Anxiety, pain, and health all kind of go hand in hand. So I really stopped to try and think about what I could do to help her kind of calm down in that moment. During my shift, when the patient first expressed concern, I used therapeutic communication, notified the doctor of her concerns using SBAR. I consulted the chaplain, administered PRN medications as needed, and at handoff, when the patient again became tearful, and I would like to say those interventions did help. I think that was just one of those days where she was really struggling, and I think she just needed somebody to kind of stay with her for a little bit. At handoff, when she became tearful again, I stayed with her, sat down at eye level, and let her talk things through. I tried to refocus on what we could do in the moment and shift away from what we could not control. And when the patient asked if I ever had anxiety, I told her that I actually do. I have baseline anxiety issues. And and I talked about a really useful grounding trick that I've used in the past. So I had a request to go over my grounding trick. So it really kind of focuses you in on the moment. You list 5 things you can see, 4 things you could touch, 3 things that you can hear, and then 2 things you can smell, and 1 thing you could taste. It kind of makes you go through and use all of your senses to bring you back to the moment and be present where you are. I stayed with her for about 45 minutes after my shift until the patient was smiling again and showed me that she was relaxed and that she felt ready to go to bed for the night. My complications, the only complication was kind of the timing at shift change. I didn't really want to leave her in a state of distress. That wasn't really a good way to set my teammate up for success or my patient, so I stayed after bedside report. We finished with our other patients, and then I came back to our patient and I sat and talked with her for a while more. Final outcomes, she was able to relax. When I came back the next day, the nurse told me that she actually had slept pretty well that night. And when I saw her again, she actually thanked me for staying with her and working with her. Duffing's caring factor, I used attentive reassurance and encouraging manner. And for my HRO tools, I used the STAR, Stop, Think, Act, and Review to try and find a unique way that I might be able to help her through that. Okay, whew, I'm sorry, y'all, those were emotional stories for me, but going on. So my clinical resource, I acted as monitor tech. I listed my dates out, and I actually got it signed by Lynette Campbell since I was acting as a clinical resource for PCU and ICU as their expert monitor tech that day. I also included my monitor tech competencies to verify that I was competent to do that. For my competency assessment validator, I was an expert. I did 8 hours of competency validation in skills lab and private EKG exam tutoring. Exam tutoring, and then I also administered the EKG exams, and then graded those and turned them into education. For my evidence-based practice project, we did one regarding our HCAP scores on medication administration. I know you've probably seen this EVP before. I worked on it as a team with Megan Williams and Alicia Santos. We did this together back in fall of 2018, and we were able to go through and kind of do an assessment of patients' knowledge about medication assessment side effects based on our HCAP scores. We came up with an intervention. We worked with our nursing scientist, Dr. Jonelle Wells, and then we also looked at what evidence base had. We utilized our nursing librarian to get us some different research topics, and based on that, we created our intervention, got it approved by management as well as other interdisciplines that we had to work with to help kind of do the intervention, and then we ran with it. We did see an increase in our HCAP scores. It was pretty interesting to watch. We also followed up with our peers. We did a lot of education, but we also tried to get feedback on what was working and what wasn't, and kind of tailor it as we needed to. For my last clinical 2 activities, I was a charge nurse for 2 activities worth of hours and shifts. For my CEs, I have the greater than 60 hours of CEs, and I included all the certificates. I tried to do them in the order that they are listed on the CE record of contact hours. Going forward, for my educational, I used my time teaching as our outpatient, inpatient elective joint camp. So for people coming in for their elective joint surgeries, we did a camp where they got to come and we kind of talked to them about what you can expect before surgery, during surgery, and after surgery. It was a lot of fun. I helped create the PowerPoint originally with Lucky, and then I went every other week and we presented it, and I did the med-surg part, and then sometimes different people could or couldn't come. So usually it was me and PT pretty consistently, and it was a lot of fun. I really wish we still did that, but I know we're looking forward to doing it again, so I might get to do this again. That was one of my favorite activities that I've done, was teaching the class. Who Cares for the Caregivers was the name of my poster presentation. I did a little slideshow so you could see exactly what was on the poster. I also included pictures. I presented it at our huddles and our staff meetings. And then I have my sign-off sheets verifying that it was done. I also included the slides from Joint Camp as well in my education section if anybody would like to kind of see those, because it was a lot of fun and I thought it was a really cool thing that Alliance did. For my professional activities, I did the P1 professional organization in 2019. I attended the TNA ANA Policy Summit and House of Delegates. I actually went as a delegate representative, so I went to both the Policy Summit where we did a lot of review and a lot of CEs, and I also did I went to the delegate day where we actually got to vote in for different TNA policies and our TNA chair members. It was a lot of fun. It was very interesting. I came back after that and I distributed the information to our unit. I met one-on-one with a lot of people. I had it hanging in different parts of the unit, and I also included that here, what information I distributed, and I talked about it at several huddles and staff meetings. I included my TNA and ANA membership card. I also included my, it was like my identification badge that identified me as a delegate, as well as what district I was from. Also, I really encourage everybody to be a part of TNA. It's a lot of fun. You learn a lot of really interesting things. For my other professional activity, I have been the chair of Nursing Congress now for the last, since November of 2018. At that time, I was elected co-chair, but we found out in early January, late December, that the chair I was supposed to be learning with was no longer going to be staying with THR. They were actually moving out of the state, so I became chair. So I've been chair since January of 2019, and I will be ending my term at the end of this year. I've had 100% attendance, and I have a letter verifying that. And then my other professional activity that I chose was that I was in UBC, and I have a letter verifying my council attendance with UBC. I verified that I've attended 100% and that I've been involved. And then I had some other activities as well, but I think that's all I need. So if y'all have any questions or if there's anything else that I need to review or redo, please let me know. I'm sorry this was so long. Thank you for staying with me. I appreciate all of you, and I look forward to hearing back from the committee. Thank you.